Right. Anthony?
Got it. Yeah, shared screen and now options. I'm not quite on this particular one. How do I change the slides, or can I get you?
You
Can I
can
get you to?
I can do that for you, Anthony.
Would that be okay? I'll just
Yes,
say
yes.
sort of slide.
No worries.
Okay. In which case, I don't think there's any further. I'll just go straight into. It's there is a lot of information. There's a lot of curiosity, and I'm really sharing with you my anxieties and my concerns about how things seem to be working. And I haven't met anything in the last year or two to make me doubt that what I'm thinking is not right. There's no doubt in my mind that that is the right set of thinking. But I mean, coming to today, I've been trying to understand the logic behind the way the NHS is financed. And I've been involved in a way, major public sector has financed in British Rail while I was on the board, could make sense of that. I was deeply involved in the way the BBC was financed. The license fee system is hardly difficult because it's so transparent. But with the NHS and how the national insurance comes into play is on the surface plain and simple, but when it's in the direct hands of the Treasury and the Secretary of State for Health and Social Care, the question is transparency, and my belief on that is not a chance. The NHS is and will remain, I hope, one of the most remarkable organizations in the world. COVID-19 has illustrated just how lucky we are through the way that many thousands of people became the core of a selfless organization. They were dealing with the murderous ravages of the disease. Our research teams led the world in finding the vaccines, and out of retirement came nurses and doctors and many others to work and face the dangers without hesitation or question. And it was the management teams of the trusts and their workforces who served in isolation and banner nursing, and where they could, they created areas of normality side by side with mortality to care for others in need. I'm going to go in more detail about the processes later, but it's important to recognize that there are fundamental differences between the way the NHS is funded and the way social care is paid for. And I've brought in social care because it's long overdue. And it's a very, very important part of how we go forward, particularly in community services. I joined the NHS in 1990 and knew very little about anything, how it worked or anything then. And I still have gaps. I was as Mike has pointed out, executive director of a priority care trust, which was being formed in Mid-Kent with an acute trust, the Medway Hospital being the next part of it. The two trusts came from two organizations which were linked together and had to be separated. There were some 8,000 staff to be separated into two organizations, and my responsibility was to set up a new organization with NHS with mandated employment requirements. And the Secretary of State for Health, somebody might remember, was a guy called William Walgrave. As a trust, we were responsible for a number of community hospitals and homes where too many were living an institutionalized life, but who, with the right support, could well be moved into the community. The question was, who was best based to take on the responsibility? And it was clear to us that local government social services was the right group. The NHS surrendered the responsibility for those identified as capable of being looked after in a well-conceived community environment. Staff, finance, and buildings were transferred to social services very successfully, but the initiative needed more money than was available, and the changes slowed, and eventually the impetus was lost within probably about 3 years.
Sorry, Anthony, are we still on the first slide or?
No, yes, we are.
Okay.
I'll give a shout.
Thank you.
And we could come off slide for a while if it helps, Mike, because otherwise it's just looking at pieces of paper. Great.
Perfect.
I'll shout for the next
continue.
one.
Yeah.
There are many changes. 1990 was a critical year. Margaret, I think you'll remember those days and how critical all the changes started then. Particularly for nursing staff, with the introduction of degree-only nursing. And that had to be, from 1990, that had to be in and working by the end of the century. So in the past 30 years, the NHS has gone from a well-staffed, possibly over-managed, certainly professionally served organization, recognized worldwide as the best of its kind. But the 1990s decision taken to redesign the nursing services changed the nursing levels dramatically. Called Project 2000. Memories, Margaret, on that one? PK 2000. It was to be implemented then, and so on. And the reasons were that they wanted to increase nursing skill levels and to narrow the medical gap between nurse and doctor. Project 2000 saw the strengths. Many saw those equally. Many foresaw the weaknesses. The chief nurse of Scotland at the time said that this is not going to work, and she thrashed much in Scotland to try and have it overturned. And she was the only nurse that at that stage in living memory who, when she retired, was not given an order under the orders system. The other link to that moment, which was the more serious in one way, was that it was decided to phase out the role of the state-enrolled nurse and surrendered the post costs as savings. Schools of nursing run directly by the NHS were surrendered with all associated monies and taken on by universities throughout the country. And at the same time, the budget for paying for nurses in training was collapsed and bursary systems opened, which meant that those wanting to become nurses in the newly created system had to find their own funding. Personally, I believe that this is perhaps the 20th century's NHS greatest mistake. Degree-only nursing inevitably raised the kudos factor for those joining the ranks, but simultaneously raised the expectation that the delivery of degree-level nursing care would mean that bed panning and hands-on low-level nursing essentials would not be in the job description. Now, to look into those decisions 30 years ago, in the way the NHS was funded, have brought it to a situation of underfunding that is difficult to make clear, and I believe is at the heart of many of its troubles. Let me try to explain some of the unexplainable, or inexplicable, as some others might say is a better word. Around about 1990, someone, somewhere, decided that the NHS should set an annual target of reducing costs by about 2% to ensure that it was making best use of income without having extravagant bureaucratic staff and becoming lean. To allow for inflation and rising costs generally, the NHS would also be given funding to cover these costs. And that was at an average of about 2.5 to 3% per year. The figures slightly varied each year, as of course, depending on what was happening financially. All at the same time, they had to reduce the budget by 2%, reducing staff if necessary, and the necessary was to get rid of the bureaucracy was there if they could, and the substantial overmanagement that was believed to be there. And however, the anomaly suddenly occurred that the 2% was to be given back to the trusts to be used as part of their overall 5% potential extra spending power in the year in question. Now, if you can make sense of those figures, damn it, would you please let me know, because I'm damned if I can. And this is what worries me. And then now, coming just for a moment, we'll come to the present and change a slide. Yes, please, Michael, if you could. Next slide. How the finances is there. 3 years ago, the Secretary of State for Health, Jeremy Hunt, accepted that a large part of local government social care was directly intermixed with health issues. He explained his portfolio, he expanded his portfolio to include health-related social care, a large segment of social services. Matt Hancock, overwhelmed by COVID-19, paid lip service to the new structure and was inevitably slow in recognizing the needs and deficiencies of his responsibilities. Now we've got Sajid Javid, who is now the holder of the post. So how is the NHS financed? 6 headlines: national insurance contributions, funding comes from those, basically for the NHS. The Secretary of State for Health and Social Care gets part of the budget, and that section of the budget is allocated by the Treasury, and it's based on the previous year's budget. Rising costs have to be bargained for. Cost of living increases are determined by the Cabinet and Treasury. Negotiated salary increases have to be agreed and argued for as well. NHS senior management, where do they come in? They set out their total budget requirements for the year based on arguing where necessary for increased funding, where a need is identified, but they are handed what the Secretary of State and Social Care wishes to give them. Local Government Association. The Local Government Association is funded by in other ways, and we'll come into that, but they get the same treatment from the Secretary basically as the NHS does in what they're allowed to spend and how they're allowed to spend it. And I mean, we know with the Local Government Association, they fund social care, children's services, vulnerable people, the whole of the social service sector as well. Now, clinical commissioning groups have, during the last years, been the organization set up to identify local needs at county level mostly, and they apply for funds to pay for the service they identify as necessary for their community. Now, there's a complete section on how the clinical commissioning groups works just coming up. I'm going to throw in an extra point at this stage. You may be very surprised to know that there is no formal line for capital expenditure. And that is important, as I'll make clear later. And then, of course, the final point, number 6 on this slide, charities and public appeals. We know that funding, a heck of a lot of the funding for the NHS is brought in by the public funding system. Mike, I'd love the next slide if you would be kind. Give you a chance just to read it quickly. Going to the next slide, Mike, please. The epidemiology that we've just looked at is the principle that determines the outcomes. Now, how individual trusts are financed. The most important link in the funding chain was the clinical commissioning group, because they've been disbanded and a new system is being put in place. Why? Because the money they bid for is the money they use to buy the health services from the suppliers in their curtilage. And buying the services is buying from the trusts that exist, buying from GPs, buying from the nursing services throughout the community. There was a CCG for every part of England, perhaps as Dorset, covering a whole county, or where the population was more diverse, 2 or 3 CCGs, say that without taking your teeth out, please, were involved in the work. Because they examined minutely the kind of populace they were responsible for, taking into account the ethnic mix and perhaps special needs groups, the age groupings, the social mix, the poverty and self-sufficiency. And CCGs ensured that the acute services they commissioned were in places where they were needed. They might have a hospital on one or very close to a border of their care. And they would try to ensure that the mix of services was relevant to their community and across their borders. I'm going to use Dorset as an example of a CCG, and I hope you'll follow the ins and outs of the ways the needs of a community are identified. The epidemiology slide really is the basis of the way service needs are identified. How groupings of people can determine how much money can be allocated to their care. The geography of a county can identify problems because the way a county border may divide a town will show how the costs associated with a family can be borne by another CCG. So here goes on that. The Dorset CCG, there were about 300 whole-time staff, ranging downwards from a chair and a chief operating officer, with a working board, secretarial and clerical support, and so on. And staff costs were about £12 million. Now, if you think of £12 million and 300 people, it sounds an extremely high value. A substantial part of the staff were clinically based or a very senior NHS management level, because they were dealing with the absolute details of the needs of a whole population in a population in Dorset of over 750,000 people. And for Dorset, there are 5 NHS trusts. There's Dorset County Hospital, which is a foundation trust, acute. Dorset Healthcare University NHS Foundation Trust, which includes mental services and primary care. And I'll make a point about that in a second. Then there's Poole Hospital NHS Foundation Trust, which is an acute trust. The Royal Bournemouth and Christchurch Hospitals NHS Foundation Trust, which is acute. And within the of the county, there is the Southwestern Ambulance Service NHS Foundation Trust, but this is not included in the CCG. Dorset Healthcare University is the biggest of the trusts and deals with all GP services and other services which are not part of the acute trust systems. They are both the most diverse and biggest user of the funds available. And to make a point, it's essential to identify the special needs within the population because different groups attract different capitation allowances. And I'll give you two examples. Dorset has the highest percentage of people over 65 of any other region in the country. The costs associated with projected healthcare for an aging population is far higher per head than for younger people. Therefore, Dorset attracts a higher rate to cover for these projected costs. Elsewhere, a CCG community having a younger mix of people may have a lower capitation contribution, or there may be a younger and below middle-aged people where maternity needs are identified. It's as detailed as that. CCGs reviewed their needs every few years, and each review took about 3 years to complete and cost about 5 million to do. This is out of patient income at the end of the day. And they drew up a detailed examination again of the epidemiology, the trends in needs, capacity for the acute hospitals that they had, the needs for acute services, the news for every variety and evaluation of what was being provided and its effectiveness. And now to be a little bit of fun from my point of view. Dorset has a large part of its population in the north of the county. In Shaftesbury, for instance, the nearest acute hospital is in Wiltshire. Salisbury comes under a Wiltshire CCG, and it is there that people from North Dorset needing acute services go. Salisbury treats people on a postal code basis so that they can charge the Dorset CCG for treating Dorset patients. Dorset borders 4 other counties. People living close to the borders, but on the other side, may well be treated by Dorset-based GPs. And there are over 30,000 people who are treated by Dorset GPs who live in Wiltshire or Devon or Somerset. And as with the acute hospitals, Dorset CCG recovers their costs by use of postcodes. Now, there had to be public consultations on all arrangements the CCGs wanted to make, giving opportunities for the population to express views and concerns. And Dorset CCG wanted to close the last 16 beds in Shaftesbury's Westminster Memorial Hospital. And this would affect people from Wiltshire and Somerset. My role on behalf of the council was to bring all stakeholders together to discuss what sort of approach we were going to make to the CCG. And this involved the Somerset MP, the Somerset CCG, Somerset Council, the same for Wiltshire and from Dorset. There were reps from the Hospital Friends, Shaftesbury GPs, a selection from the community people from across the borders who were referred to the hospital. We met with members of the CCG to argue our case and collected 6,000 signatures against the proposal. We held 3 public meetings with an average of 300 per meeting. And we discovered that the CCG had not assessed the planned housing numbers in, i.e. population growth, which would have brought in about 3,000 new people into the area over a 5-year period. They'd left them out, and therefore funding for those would be full they would be falling short of funding for about 3,000 people over the period. And they had not talked to their opposite numbers in Wiltshire or Somerset, and weaknesses mounted in their case. And when they finally announced their plans, they revoked the closure plans and set up a working party. And this was a first, a working party between the CCG and members of the community that they were looking after. We also discovered that they had had extensive meetings with Hampshire County Council and Hampshire CCGs and Hampshire Social Services about the numbers of the Hampshire population, mainly from Southampton, who were using the Poole and Bournemouth hospitals. Equally, many Dorset people were using Southampton. So I hope that might give you some idea of how the money flows and doesn't flow, or has to be recovered in an annual period across various areas of the NHS services. Next slide, I would be grateful for. Just a quick point on capital expenditure. I've raised the question, where does the cost of an MRI scanner come from and how does it affect a trust budget? Very simply, the cost of an MRI scanner was, and certainly it was about £1 million. And it comes from the revenue that the trust has for its general purposes. It doesn't come from a capital budget because there is no one. And taking it out of revenue means that £1 million spent is £1 million less available to spend on nursing and direct service care. And exactly the same thing happens for maintenance repairs. I don't know whether has anybody picked up recently in the last 2 or 3 days. There was headlines in one paper and headlines in several others to say that a number of hospitals throughout the country were finding that their buildings were in danger of roofs falling in on particular events. Now, part of the problem is that if you don't have a capital expenditure budget, how do you find the money to repair a building that you've built if that has to come out of revenue? And if you're going thin on money in revenue, repairs, as with school repairs, get very much lower in the scale of things. So it's a bit nonsensical. So maintenance, repair, and repairs, all of those things take money out of the system. Now, I'm only taking a moment to make certain that I haven't missed out of a slide, because I think I have. It doesn't matter. Mike, could we go on to the next slide? The NHS and social care. Is true integration viable? And who manages combined teams? It's very difficult to explain what is meant by social services these days. I mean, the range of needs and how they're delivered is very wide, stretching from care for the elderly through mental health services, children's care, care homes, legal care of children in difficult circumstances, the homeless, probation services, a whole range. And care in the community in 1990 was designed to hand to social services responsibility with supported needs, who it was felt would benefit from social care in their own homes or in assisted living. But this is simplistic. And I acknowledge care in the community has never achieved what was expected from the changes. But subdividing social services and deciding which of its many responsibilities fall within the new NHS social care brief is a challenge. Social services in local government are massively underfunded, Resources and finances transferred from the NHS 30 years ago have long been absorbed and subjected to different approaches. Where they overlap, they are facing huge differentials with the NHS in job funding and equal pay factors. A nurse in the community services of social care is paid 30% less than a nurse in the NHS. And it's exactly the same with healthcare assistants. And the costs of social care need substantial injections of money. From where? I leave that question with you. Increased council tax precept. Local government association believe the NHS must transfer resources. And I raise the question again, from where? Next slide, please, Mike. This is, I'll be as quick as I reasonably can on this because we're getting sort of, you've listened to me very carefully for too long, and won't be much longer. This is more of a summary of the points I've covered, and when it's over, I'll be open for questions. What I've outlined is based on my time working for the NHS and also the 3 years as a town councillor for Shaftesbury. At the start of this, I talked about the way the NHS annual increases were worked out. I'm not mathematical, but I believe the formula that has been in place for so long has the effect of reducing the annual budget each year, and I cannot work out by what by percent. When you realize that there's so many actual costs, annual costs that have to be met from income, capital costs, renewable old clinical machinery, annual estates maintenance, general maintenance, purchase of replacement computer systems and so on, you wonder actually how much is going to be left for doing the real thing, which is treating patients. A 2% cut in budget year on year, an addition to the budget of maybe 3%, the figures just don't add up. The original concept was to make sure that individual units, trusts, were as lean as possible and that unnecessary staffing was reduced. And once that had been achieved, you then have to start cutting into the real core of the trust, clinical staff. You can outsource catering, you can outsource cleaning, but experience has shown how many of the outsourced services over the years have been brought back into the NHS. And 30 years ago, the NHS employed many, many more nursing staff than it does today. Again, from what I've seen and learned since coming back into contact with the NHS has been reducing nursing posts to meet savings targets. And this has compounded the pressures on existing staff more and more. The population has grown. Acute hospitals are busier than ever, and not just because of COVID-19. It's impossible to assess properly the amount that the NHS needs to bring it back to an organization capable of providing the full medical and nursing services the country needs. My personal estimates of this is that it would cost between 3 billion and 5 billion a year in additional money. And that's just money. The country is short of trained nurses and doctors. The announcement several days ago that the cap on medical training GPs had been lifted to allow a further 20% per year to apply for training is a major step. Removing the cap is one thing, actually ensuring that the extra funding for the courses is also increased is another. And it will be 7 years once that has been activated before the extra doctors are ready for joining the services. I think at that point, you probably would prefer to ask questions than to hear me rattling on about anything else. Mike, can we lose and go back to full? And you